Hi, Elaine. Okay, we're back live. This is Senate Health and Welfare, and we're joined on screen by um, Elena Bereby. And why don't you know us? You've been in here before, and we would welcome your introducing yourself to us and then giving us, showing us your PowerPoint, your slides.
Happy to. Yes. Okay. So thank you for having me, Elena Bereby. I'm the former Director of Health Systems Finance and Policy at the Green Mountain Care Board, but I'm here on my own accord. I'm now at Dartmouth doing health services research, and apologies for I'm recovering from illness, so I'm not my usual self. But so I'm at Dartmouth working on my PhD, specifically focused on access to primary care in rural areas. So I will share my slides now. Let me know if you can see them. Okay. Can everyone see them on the screen?
Yes, terrific.
Great. Okay, so I'm going to walk through some kind of broader concepts, touching on some of the things you heard about earlier today. So I think at a high level, I'm hoping to cover, healthcare spending and the market for healthcare. What do we mean by healthcare market? Why can't people just get the care they need at affordable price? Payment models and behavior. We talked about incentives a lot earlier today and making sure we get the incentives right. So I'll talk a little bit about that. And then state tools to make healthcare markets work.
Elena,
Yes.
is it possible you can turn your volume up a little bit? It's coming through fuzzy, and I think just volume help.
It
could just be me.
It could be me and let's see. I'll get closer. Is that better?
Right. Yeah, that's good.
Okay, all right.
We won't catch it.
Okay. I hope not. It's no fun. So I wanted to start with a high-level view of how healthcare is funded in the US. So, who foots the bill? I'm not going to spend time getting into the weeds, but just to say your premiums are only kind of one piece, right? So private households pay taxes, federal taxes, state taxes. It goes to, various middlemen who also take a chunk out of what you've been paying or not getting in your wages. And then eventually it ends up going to providers. So, there are many ways that providers get paid and many ways that individuals pay for that care. So why do we spend so much on healthcare in the US and in Vermont? So the US healthcare system is rife with market failure. So what does this mean? This means that the resources that we need to receive healthcare services do not necessarily match where we need to be receiving them. We also have a misalignment of incentives. So individual behavior and group outcomes are not necessarily aligned, and we'll talk about that in more detail. And this all leads to spending waste, so excessive administrative costs, excessive prices, greater than necessary use. And I think you've heard some of that this morning. So why doesn't it work? We have poor information in a healthcare market. So patients have less medical knowledge than providers and don't have a great sense of what the value of a service is in some cases. And this can lead to inefficient decision-making or possible overconsumption or overpayment for services. I had a great experience. I have a wonderful dermatologist, but I remember her asking me, well, don't you want that peace of mind, that peace of mind? And I'm like, yes, but I also have bills to pay, And so it's very hard for people to make these decisions when they're feeling emotional. So that was one of the other items. People are not rational actors. Healthcare decisions are emotional. This can lead individuals to overspend care that only yields marginal returns, or, they can even go into debt when they think they need care. Sometimes they do need care, they just don't have the choice. So that's not to say that all healthcare decisions are non-optimal. I skipped one, conflicts of interest. Patients and providers may not share the same interests, so maximizing healthcare revenue versus minimizing healthcare spending. So I think this is one of the big ones, and why we're all here today trying to figure out where to go next. A lack of competition. There's high startup costs to participating in the medical field, whether you're a professional or you're a facility. Equipment, medical degrees, these things take time and money to build. Particularly in rural areas, there's a lack, an extra layer and a lack of competition just because we don't have the volumes. You have to drive further to access those services compared to more dense areas where you could also have lack of competition if you have too much consolidation in the market, for example. So that's when one organization tends to own all of the healthcare services. One or a few. Okay, so attempts that have been made to fix these market failures to help it work better. One example is the ACA. So previously we had eligibility based on pre-existing conditions that led many to not be able to afford their care and created instability in healthcare markets, health insurance markets. We also have, whether we have high or low relative purchasing power in some geographies. So as I mentioned, we have low volumes in some areas. It may not be financially savvy to go serve those populations when you could go serve another population that has more density. So the ways that we have overcome this is either through direct government provision. So U.S. Veterans Healthcare Administration kind of does this centralized planning and then puts buildings where their veterans can most aptly access them. Provider subsidies. So we have HRSA grants for FQHCs. These are particularly to incentivize the opening of primary care and dental care in these, complex care management facilities in areas that are underserved. And then there's planning and oversight. So CON or some of the health resource planning you heard about this morning that can help identify where there are gaps in access or opportunities to kind of make sure that, or at least highlight where there's opportunities to address the mismatch between demand and supply of healthcare services. Monopoly pricing power is another one that you may have heard about in discussions leading up to this week. In healthcare spending growth and related monopolistic behaviors. So some remedies for this, other states have implemented market oversight of healthcare providers, and Connecticut, California, Massachusetts, and Oregon all have processes that before there is increased consolidation, and so one organization wants to go buy, let's say, a physician practice, that they understand the ramifications for the practice, for access, for pricing, et cetera, that will happen, and they kind of do an analysis and a public process around it. We heard also about price controls and spending caps from John Colmers in Maryland, fee-for-service rate setting and hospital global budgets. Another way to do this, Rhode Island has affordability standards that it establishes through its insurance review process, and that really puts a cap on hospital spending. So it's another way to get at price controls. Transparency and information sharing. A number of years ago, there was a hospital transparency rule. I think, there's limited support that it has actually changed the way that consumers can interact with their healthcare cost information, but it is helpful for understanding where there might be monopoly pricing power and other related issues. And then misallocation of healthcare dollars to sick care at the expense of preventative care. This was why the state kind of pursued the ACO, I think, to begin with. It was to think about financial incentives to reallocate and make, have financial gains from serving people before they get sick in a preventative setting rather than having to pay for more expensive and costly intensive care down the line. And so there are some financial incentive programs like the Medicare Shared Savings Program and various quality incentive payments that seek to kind of address those challenges. Okay. And at any time, feel free to interrupt me. I know we're moving quickly, so if you have questions.
Thank you.
So I wanted to highlight kind of the concepts behind some of the payment models you've heard about. And then I'll kind of talk through some examples and what it means for incentives. So a capacity-based payment model is a payment for the future capacity for a range of services. This is often to a facility to make sure that we will have services available when we need them. Usually there's a floor. You could have a floor involved, so this facility will get a minimum of X dollars, or it could also be to limit excess growth, like a cap on spending at the facility level. You could also have an activity-based model. That's when you pay based on a unit of service delivery. So examples of this are fee for service, other kinds of bundled payments. And this encourages greater use of those services, more services, more revenue. And then you have population-based payments, and these are models that pay an organization, so largely an intermediary organization, to manage care for a population, encouraging greater use of more preventative versus acute care in lower cost settings. This was kind of the one care model, or that we had hoped that it would move to this population-based payment. And so what you heard about today, I think there oftentimes payment models are a combination of these. So if we think about the Maryland model that you heard about, it's really a combination of a capacity-based and an activity-based payment. So on one hand, they're paying for every unit of service that comes in. On the other hand, they're establishing a cap for that facility based on the volume of services that are delivered. And so you can kind of work across these and combine them in different ways. So how does payment and these payment designs matter? I want to briefly return to kind of one of the premises in finance. Many are probably familiar with that profit is really revenue minus cost. So if you want to increase profit, and even nonprofits care about this, they just end up reinvesting it in other ways. But you can either increase your revenue or you can decrease your cost. And that is important for the health of the organization. It's important for being able to pay your providers and for continuity of services. So this is one of those key equations. Oops, wrong way. Okay, so in fee for service, revenue equals price times volume. So you set a price for a service, and as I said, you've heard already today, volume of services determines how much revenue you bring in. In Medicare right now, traditional Medicare sets the fee for service based on the cost of production. So they collect cost reports from hospitals and estimate what the cost is of delivering those services, and then come up with a fee schedule at the service level based on what they think it costs. Medicaid is generally determined by the state and usually starts with Medicare and then makes some adjustments, but generally pays less than Medicare. Some states are more generous than others. Certainly Vermont is one of those states. Although we are not at the tippity top, we are kind of closer to the Medicare amount. Commercial payers negotiate contracts and set prices per service oftentimes. So what they'll do is they'll take kind of the charge master, which is like the list price of a service, and then say, we're going to pay you 70% of what you have listed as your price for that service. And fee for service, as we mentioned, has repercussions for volume. So if you change prices per service, you're going to see changes in what hospitals do. This is from a CMS actuarial report, and it's been replicated in a number of different research settings. You can see between 1994 and 1996, for procedures, there was a reduction of price by 27%, and you see a commensurate volume increase by 17%. They also take advantage of price increases, so you'll see an increase in visits by 14%, compensation for those visits, and a volume change of 84%. So, depending on where you're going to be making your money, sometimes you have organizations paying attention to those kind of high value, high margin areas. Okay. Capitated payments, on the other hand, so so fee for service is based on, activity that's been delivered. A capitated payment is like, I'm going to give you a grant at, let's just say, a facility, and this is what you get. It's a little bit different. So Kaiser is an example of this. Medicare Advantage is another example of this. You get a fixed amount, and then you're supposed to manage the care within that budget. So in this case, your revenue is now fixed. So the way that you get to higher levels of profit is really to manage your costs. And this can look different in different scenarios. So I think, as we know, in the Medicare Advantage space, there's quite a bit of controversy because you can, really manipulate who gets care and who's excluded from care. And this might be one way to realize your profits. Another way is to think about redesigning how you deliver care. So I think you heard about in Maryland, these emergency department visits. If you're kind of overburdened with emergency use, are there other ways to move those patients into lower cost, lower acuity settings where they might get, better care, their urgent care opportunities, primary care opportunities. So it could be a matter of redesign to kind of manage those costs. So when might fee-for-service or capitated payments make sense? So fee-for-service or episodes or activity-based payments might make sense when your supply of services is less than your demand for services. So that means you have access challenges.
Elena, I'm
Yeah.
gonna ask you to slow down just a little
Sure.
bit. So, because what's happening is you've got a huge chunk of information and you're reading through very quickly. So I'm gonna ask you to back up 2 slides,
Sure.
or 3 slides rather, go to capitated payments again. And
Yes.
just go through that, please, again, and then continue on, because now it's getting to be a fire hose on
Of course.
caffeine or something.
I'm happy to slow down.
No, it is, of course it is, but that's the point is, we need to slow down so it sits in our brains and allows for us to do comparative analysis with all of it at the
Sure.
end.
Okay. Great.
Some of us can do that now, I know that.
Okay, so and these are a little bit, these are challenging because they're kind of unique situations, but Kaiser is a vertically integrated delivery organization. So that means it is an insurance company that also owns hospitals and providers. And so they budget for all of their healthcare expenditures for a group of beneficiaries, and then providers work together to manage the overall budget. And so managing the care for that population and managing the costs of delivering that care. So in this case, they have this budget, and they are incentivized, as we saw in the previous or the next, to manage their costs together. So that means if I have an opportunity to move a patient to a lower cost setting, let's say primary care instead of emergency care, they will have a process to be able to do that and work together to manage that because they're in control of both the revenues and how they flow and the organization that's providing that care. Medicare Advantage. So our federal government has 2 flavors of the way they pay for Medicare. One is the traditional fee for service. So patients go wherever they want and they pay for or to Medicare accepting providers. They get their services and then the bill goes and it's, based on what services they received. Medicare Advantage is when Medicare pays a private company to manage care for a population, and they get a capitated payment. They get a fixed amount of money to provide care for that patient throughout the year. And what Medicare Advantage companies do is find ways to facilitate care delivery to the patient in more cost-effective ways. They also have kind of the opposite effect where with, this, I don't want to get off the rails, but I think it's an important thing to remember. If you look sicker, you get paid more money. And so there's kind of an incentive to kind of make patients look sicker based on kind of the codes and their service needs. But if we're just talking about costs, there is this incentive to make sure that the patient is getting the lowest cost care to still achieve their needs. Does that make sense? Questions there?
Oh, that's good.
Okay. So as I mentioned, because the revenue is fixed, the emphasis is on costs. And so if this is at the facility level, that might look different than if you're an insurer and you're managing kind of your fixed costs or intermediary like Medicare Advantage. Okay, so as I mentioned, there are multiple ways that you can manage your costs. Some of these ways are not great. So not giving people care when they need it is a big risk in some of these capitated models that are, strictly capitated. But they also are an opportunity for thinking of redesigning if the capitation is kind of at the right level with the right incentives and the right oversight and outcome performance measures that we want to see for care. So capitation could be a tool for thinking about how we redesign care and incentivizing care earlier in the care delivery spectrum, and in lower cost settings, as I mentioned before.
Can you, I know this is a divergent, a side road, but commenting, the word rationing is scary to a lot of people. And it is. I mean, so it suggests that we're going to limit your access to what you need. Is this something that places that have these managed care programs, and I'm thinking of other countries where we might see the result of their work being rationing, and what goes on? To comment on that.
And that you read the fine print, it says Canadian in that blue section.
I know, that's why I asked it.
Oh,
Canadian.
that's potentially avoidable. Sorry, I should have picked a different example. I mean, I think potentially avoidable emergency visits is a issue in many different settings.
Yeah.
But yes, rationing is scary. Rationing means that patients come to get care and don't get the care that they need. And I think, we have a lot of protections for that here. So if you go to the ED, they have to serve you. You don't have that in every setting. And so it's just something that we want to think about if we move towards capitated models at some point, to have a really good idea of when people are getting the care they need and when they are not, and having a way to measure that. Making sure you have the right incentives that they get the care they need when they need it.
Thank you.
Yeah.
So it's not always a bad word, but depends on how you define it.
Yeah, it depends how you define it, how you design the payment, and then kind of, I think payment without understanding what you're getting for it, and without some goals of what good care looks like and ways to measure that is the other piece, right?
Yeah.
So, when might each of these make sense? I think these, more capitation focused models, when you have oversupply, people are getting too many services that perhaps they don't need, when the cost of delivery are too high, when you want to incentivize redesign, when spending is too high overall, that could be one reason, or when you have demand that's less than supply, but that you want to preserve capacity. So I think some of our more rural hospitals where they don't have volume to really sustain themselves, but we want to make sure they have a footprint, we might want to think about having, and I think, I'm talking about these two extremes, but it doesn't have to be one or the other. There are combinations of these models. And so I think Maryland is as I mentioned, was an example of that. But I think, if you do move to the capacity-based model, in either case, you kind of want to monitor and make sure that there's not kind of unwanted rationing that's happening. On the activity-based side or fee-for-service side, this might make sense when you don't have as many services as perhaps are needed. So when you have wait times problems, or access challenges, you kind of want to incentivize more service delivery because there isn't sufficient levels. You might, fee for service or reference-based pricing might make sense. But you want to make sure that those prices can be controlled directly, and that you have a way to figure out what the right prices are. So as I mentioned before, Medicare uses kind of this cost accounting method to determine what those prices are. So you can, theoretically think that's why a lot of people have leaned in on reference-based pricing to use Medicare as a base, because they've done that work already. But then if there are places where, your policy differs from Medicare, or where Medicare doesn't weigh in, like for example, on pediatrics, what does that look like, and how do you determine that price? And here you still need monitoring to make sure that overutilization doesn't happen, so that you don't fix the supply problem, but then kind of tip the other way. And so I think really thinking about what you heard earlier today, and thinking about where Vermont is, and thinking about this as a process, and a learning process, and where are people getting the care they need, and where are they not getting the care they need. And I think if this planning, maybe it's on the next. Well, I'll get there, but so let me back up. So every system is perfectly designed to get the result that it gets. So it's not just about selecting an approach, but how the whole system works together. I think this is why the Green Mountain Care Board was established, is so it had kind of this broad view and lots of tools to kind of connect the dots. So which services should be paid and how much? How do we make sure payment encourages or discourages the utilization that we do or don't want to see? How do we know if access is improving or not? So these are all the things I was just talking about. Are people getting the primary and preventative care they need to avoid more costly care down the line? So we really need systems to identify and know this, and then we need tools to address when it's not working. So I'm sorry to say there's no silver bullet, but taking advantage of opportunities and addressing the risks associated with any of these payment models can best serve the public if we really focus, our efforts. I believe in a strong agency that can both evaluate our health system, plan for what we need, and then use payment reform to implement an incentive structure that moves us in that direction. And that takes people and resources and collaboration. So I
Thank
will
you.
stop there.
That was a great overview. I can tell you how much it helps for the committee as a whole. So thank you. But I'm disappointed because we wanted the silver bullet. Darn.
I'm sorry.
Space pricing is the silver bullet.
It's getting there, isn't
Out
it?
in the population.
Yeah, right. But you just can't,
do
you
that
can't,
and it'll be fine.
you can't do it without a framework. So as we're looking at payment changes and incentives to encourage, for example, if we're going to provide an incentive for hospitals to encourage more primary care. Well, one of the things that I've been thinking about that I don't think is in our framework right now, but probably should be, is when some kind of incentive that when hospitals provide or encourage independent primary care or mental health or substance use disorder or primary care services blueprint, when that happens, that somehow that be taken out, all or percentage be taken out of their total cost of care. So thinking about that, and I don't know whether you have thought about that or not, but for me, it seems like a natural incentive to shift attention toward primary care.
Right. And I think, thinking about where there are incentives and where there are other enablers. So, I think, and I have been meaning to go back and look, but I believe Maine had kind of a community co-op of independent providers, and they had this shared funding stream. So similar to the CPR program you heard about. So there might be other ways to, you don't have to incentivize hospitals per se, but what is the other mechanism that allows, greater primary care or makes primary care providers' lives easier? I think you looked at kind of the administrative burden and prior auths and not too long ago, but are there other ways by increasing the payments to primary care providers that we could, go more directly?
Well, you've already mentioned one. So if you have a list, something that we might triage or look at what might work in Vermont, send it along. Send it to Kiki and copy me, and then we'll put it up. We'll have a whole committee look at it. That would be great.
Great. Happy to do
Yeah,
that.
no, because that's one of the goals here. I think we see the imbalance, and as you were saying in the beginning, prevention and primary care that keep people from the acute care needs and chronic care needs. So, good. Any other questions for Elena? This has been super. Don't leave. If you can, stay on. I know, drink some orange juice, but something good to take care of yourself. I'm sorry you're sick. It's unfortunate.
Happy to stay on.
We'll get you back in at some point. Great. All right. And so we have someone well, and Elliot Fisher is here. We have some time. So Elliot, thanks for making yourself available to us.
Well, great to be here. Cool, Elena, good work.
Please.
Maybe so I can see where I am with that mirror. I'll try to turn on my,
Okay.
use my slides. I think I'm in
Yeah.
the room.
Yeah.
Now,
Go right ahead.
figure out how to share my screen. Share my PowerPoint. Information with the exclamation point. All right, let's see what it does. Yeah, open.
This is
And FYI, I know that you had suggested, so Eric Cooper,
Zach.
was it Zach? You can remember Zach, Zach Cooper, and he may be available to us next week, which would be very good. We won't know. We won't know until the last minute, which is why it's difficult for us to.
Yeah, well, I'll mention it. I'll just. If you
I'm gonna be talking with it. So just to share with you, thank you, because it's a good connection and I'm gonna talk with him at noontime, hopefully.
I'll just, I won't use my computer, I'm slowing things down.
Okay.
And I know Senator Hardy's already read my presentation, so maybe.
Oh, I've read it 3 times already.
So we have your presentation online and we also have it in hard copy.
Yeah.
So you just let us know next slide. It's
Okay.
not up.
Sure, and I think you may have Bill's key, so you'll have to hold me understand. So. See where I am, kind of, now, that's all right. Oh, I know, I can see it, I can see
You
it
can
from,
put it on your own.
I can see, if I look at Zoom, I'll
Can
see
you-
where you guys are.
Can you join? Do you want a
I
hard copy?
did, no, I got the hard copy, what it is was, I couldn't share my screen,
Yes.
but I can see if Kiki's got it, or
You can share your screen.
if for
No.
some reason my computer is on, this new computer
Oh, no.
is not happy, so.
Okay. Well, let's do it. We'll go through and we've got
But
your
we need to
slide.
share it for the listeners, right?
I know.
Can you-
I cannot screen share while I'm live, but it's on the website.
We can make the.
It's on the
look at slides.
website,
Let
and
me-
so
let me
folks
just-
who need to can go there and look at it, and you just say next slide, and we'll be there.
How can, well, anyway. Or yes. So, the cover slide is that 2 rows that I always think we have a choice. Robert Frost, exactly. I was going to, thank you. So the gist of my argument is on that second slide.
For just a second, we're having technical
Okay.
camera issues.
Oh, hang on. We're still live.
I had 45 minutes here. I could have set this up. I failed. I'm sorry.
So, if you can load on the camera.
Right, like whack at the bomb.
Load and the same thing. We're still live, so they can hear us doing it.
Yes, they can. And I'm going to.
So weird, not working.
Yeah.
Keep you working.
Something to do. Maybe why I couldn't do it.
Did you do anything there?
Quit Zoom.
I think you're doing it.
Okay.
Do you have your camera?
There we
You
go.
can now push mode.
Don't like that mode,
No, we don't like that. There we go.
all the camera videos.
So,
I
okay, so
think it's-
clicking mode on there is not gonna affect it. So the shot we saw is coming from the camera above the TV there,
Right,
not this camera. They're separate.
right, it is his computer.
It's my computer. It's in my computer.
What was, your computer's on the screen, but there's nothing on it.
Maybe just connect from.
I think you
I'm
need
trying
to-
to even find Zoom on here. It's not even showing up on my device and stuff. How about a